Go ahead. Go ahead. I know, somebody talk.
Coronary disease.
Yep. Yep. Good. Some other things kind of specific to hospitalized patients. Have they had sepsis with recent low blood pressures, right? Have they had recent contrast exposure? This could be the MRIs, well, not so much MRI, but CT, coronary angiograms that they've gotten. Mm-hmm. Yep, good. That would kind of go with the ins and outs, the weight. Mm-hmm. Good. I'm just going to go through my slides a little bit. All right. Let's maybe move on to physical exam. So when you talk about like urine output, just know that sometimes you'll see that we classify it by amount. And those are the amounts there. So like you'll hear people say they have anuric acute renal failure, ovouric acute renal failure, non-ovouric acute renal failure. So you'll hear it classified like that. Basically what it's saying is just the amount of urine that was produced in 24 hours. So what are some, when I think about physical exam, like what's important to really assess on a patient with renal failure, it's really volume. So think about volume status. And then also think about neurostatus. And also think about rashes. So from a volume status, what might you see on physical exam? Somebody with acute renal failure. Yep. Elevated GDP, maybe an abnormal heart sound. Yep. What about neurostatus? What might we see? Yeah. Yep. Hypertension. So they'll say their BUN is like 100. Confusion. Sleepy. Yep. Attended. Esoterics. You might start to see that. Seizures. Yep. Good. This is one of those not very common things, but different reasons for acute renal failure, like glomerulonephritis is often associated with infections. Sometimes those patients can get rashes. If they have more uremia associated with it, you can start to see those petechiae rashes. It's not uncommon with uremia for platelet counts to be dropping, so we get these kind of petechiae rashes. But that's definitely more uncommon. Yep. Let's see what else. What about in your abdominal exam? What might you catch? Ascites, yep. Maybe a big distended bladder that's full of urine.
Could have like
Mm-hmm.
or like lower abdominal, depending on if they have their own kidneys or
Yeah.
if they got an upgrade.
Yep, absolutely. So that's important to think about. Like if they've got a second stone, that remember how if we're pain here, that kind of radiates down where the stone is. But then also think if they had a kidney transplant, remember when they transplanted kidneys, they put them lower in the abdomen. So maybe they're having lower abdominal pain. They've had a transplanted kidney and now there's an infection there or something that's causing the kidney injury. Yep. Good. What else? Okay, so now we're going to work through kind of a differential diagnosis as to why patients get acute kidney injury. So before, when we've taught you differential diagnosis, we taught you more from like a system perspective. And now that you guys are starting to obviously learn more, start thinking of differential diagnosis now, not so much from a system perspective, but as a disease process perspective, okay? And so when I think about acute kidney injury, that's kind of how we start to think about things. So here's your kidneys, here's your ureter, here's your bladder. And so this is your aorta here and your renal arteries. Okay, so think about pre-renal failure as all things that happen to blood flow and perfusion, hemodynamics before it gets to the kidneys. Okay, so between pre-renal failure, that's going to be like 90% of why patients get acute kidney injury. Yeah.
Do you mind just moving on? It's kind of like right behind the monitor for us. Your picture is behind the monitor on the podium, so we can't see.
Oh, gotcha. I was like, how can you not see that? Because it's so beautiful. Okay. So here's your aorta, your renal arteries, and your bladder, and your kidneys. Okay, so pre-renal failure is anything that happens like before the kidneys. So it's changes in blood flow, changes in hemodynamics, and it's going to be like, honestly, between pre-renal failure and then advancement of pre-renal failure to acute tubular necrosis. That's going to be like 90% of what you see. And so that's why, like I said, in doing this, I didn't want to get so caught up on the things that you sometimes might see and waste your brain power. So you can like remember this stuff. This is going to help. So pre-renal failure, again, anything that happens before the kidney. So the kidney itself is not damaged. All of the changes in blood flow that have caused the creatinine to increase. So what, kind of off the top of your head, what can some of those things be? Mm-hmm. Yep. So somebody, again, has had low blood pressure. This could be from sepsis. This could be from hemorrhage. It could be medication related. So you guys are getting all this in your history. So your ACEs, your ARBs, your NSAIDs, all those things that you guys just talked about. Okay. Also think of too, like, is your patient dehydrated? That's another big one. You know, have they recently had nausea, vomiting, diarrhea, all of those things that have made them dehydrated? Okay. So this is, again, just all pre-renal stuff, but there actually hasn't been damage to the kidney. Okay. So now we have intrarenal or intrinsic causes for renal failure. Okay. So the most common one that you're going to see is called ATN, thank you, or acute tubular necrosis. And essentially what this is just your pre-renal failure has kind of advanced more to actually now damaging the kidneys. The tubular part of the kidney are now starting to get damaged. So it's called ATN. Okay. And again, this is going to be 90% of why your patient has renal failure. Some of these other things aren't quite as common. So the other things that we have acute interstitial nephritis, which is most commonly caused by medications, specifically antibiotics or PPIs. And then we also have infections, which your strep is going to be the most common. And then other ones, like I said, not very common. The glomerular nephritis fits in that category as well. Okay. Does that make sense? Okay, so just remember, with ATN, all it is just an extension, a worsening of pre-renal failure for all of the same conditions. Okay.
What makes it like different? What differentiates?
Yep, and we'll get into diagnostics.
Okay.
Yep. Yep, we'll get into diagnostics. So then you have kind of the third. So this is like number 1, this is number 2. And then number 3, sort of the areas of within the kidney system that you can get renal failure. So this is all post-renal, or you'll say obstructive. So we already talked about one. Stones, yep.
Neurogenic bladder.
Yep,
Mass.
yep,
Prostate.
yep. So remember your prostate's lower, and as a guy, it pushes up on that bladder and it causes them to not empty it. So what other kind of symptoms do you think they might have? Mm-hmm. Yep. Yeah, so yeah, anuric, retention symptoms. In the middle of the night, I have to get up and pee all the time. I dribble, I can't start and stop my stream. Those are going to be the signs and symptoms that you see there for a guy. Okay. Dead stones, dead mass. Also think about too, do they have a stricture? Somewhere here within the ureter that they're not emptying out their urine. Sometimes people, because of a stricture, they get stents placed. And then when those stents are placed, those can sometimes get occluded. And then with that stents occluded, they can't pee. So that's another cause of obstructive renal failure. Sometimes people can throw clots. And it just so could happen to be in the ureter or renal artery. Yep. I'll write down BPH there for the prostate. Yeah, there's that picture of the lady's bladder there. I think I told you guys that story in advanced health assessment about my patient that was abused as a kid, and she had really bad pelvic floor dysfunction, could never empty her bladder, and that was her bladder on CT. So, yeah. Yeah. Yeah, you had one that was very similar. Yep. Okay. So now let's go into this. Oops. Oh man. All right. Let's start talking about diagnostic tests and what you think you're going to need to get and why. I'm kind of giving you the answers. But electrolytes. What's your MAD? What's your phos? What's the calcium level? ABG, what's that going to have you? Acid bases and the pHs, as their bicarbs starting to go up, they're going to get more acidic. Obviously, looking as we talked about with history, volume overload is going to be important for these patients, so you need a chest X-ray for them. Digging through the records whenever you can, and look at what's that baseline for your NDN. And for everybody, it's going to be different, right? And so there's really no way to say this is what a patient's baseline is. You just have to go back in the record and look and see, okay, over the last 2 years, it looks like they've ranged from 1.3 to 1.7. So if you can kind of get that range, that's what helps you determine what their baseline is. Okay. Whether or not you need an ultrasound, that's always a good question to ask. And then also doing a bladder scan with her post-surgery. How does that help us? What? Yeah. Yep. So the urinary retention, some type of pH that's extracting. So
getting an ultrasound, not necessarily something that you have to do every single patient. And actually, our guidelines say that unless you have concerns for more of an instructive process, you don't necessarily need an ultrasound. So, like if by history, for example, this is a pretty clear pre-renal failure. They've been dehydrated, they've been on an ACE, they're taking a diuretic all at the same time. Then there's really no need for an ultrasound. However, now if you think that they've had obstructive uropathy and now you're concerned for what is an ultrasound going to help you see? Yep, hydronephrosis. Yep, so remember really big kidneys. When the kidneys, when it gets obstructed from someplace in the urine or someplace within the bladder, those kidneys can swell with urine, and that's what the ultrasound is going to be able to do. Sometimes, just by sort of accident, so to speak, you'll see that on maybe a CT, if they end up doing a CT, and then you're not going to need an ultrasound. Okay. Do you guys know what's the normal size for kidneys? So 12 to 13 centimeters is the normal size for kidneys. So in hydronephrosis, it would obviously be bigger than that. Okay. And now when you get an ultrasound, they also look at the texture of the kidney. And so what you may find, if they're saying increased echo texture of the kidneys, that would help you understand that they probably have some underlying chronic kidney disease. Echo texture. Yeah. No, I don't think it gets it quite as detailed enough. So 12 to 13 centimeters. You want to see if there's hydronephrosis. You want to look at the texture. And then you can also get this with Dopplers. You guys know what Dopplers are? Okay. So if, say you have a patient that you are concerned that maybe they had an infarct or they have really high blood pressure, and they have stenosis, and you think they may have some renal artery stenosis. If you get the Dopplers associated with it, it'll tell you if basically the pressure is high within those renal arteries. Okay, but again, that's not as common. So the main thing that you're going to see and want to gather information about is this. Okay. All right, so let's get into a little bit of the diagnostics. Remember your creatinine in my little picture here. Do you think that these two patients have the same base? Is it the same if they have a creatinine at 1.0? No, right. So remember that your creatinine is essentially affected by somebody's age, their gender, their race, their muscle mass, and how much protein they have. So, even so, like for example, this little old lady, she might have a baseline creatinine of like 0.4, and where this guy might have 1.5, and they still have a normal kiloculture for them. Their creatinine clearance would still be sufficient. Okay, but now to actually diagnose acute kidney injury, their creatinine has to increase by more than 0.3. And it can still be within normal limits, but if they increase by 0.3, it's considered AKI. Now you'll see in my PowerPoint, and again, this is like nice to know, but don't necessarily need to know. I've got the different creatinine clearance formulas that you guys will see, the GFR. The cystatin C, to be honest, we don't check this a lot in our clinical practice, I think just because it's so expensive. The times that we have checked it is when, like, say for example, somebody's kind of riding on the line of like their creatinine clearance to be able to receive certain medications that are important, then at that point we might check it. But to be honest, we haven't used it a lot, but just know that it's out there. So the stages of acute kidney injury, again, this is like probably more information than what you really need to know. But like the stage 1, stage 2, it does define it out just in the guidelines according to how much their creatinine increased, how much urine they've actually been making. But as long as you know if it increases by 0.3, whether or not it's normal or abnormal limit, it's criteria for acute kidney injury.
This is something like when you're doing the process, like, AKA,
Yep.
to.
Yeah. That's a very good question because most people won't say the stage of the AKI. Yeah, they will just say the stage of the CKD. Yep. And this is how we would stage out CKD according to GFR. Right. Yep. Very good question. Okay. So like we talked about diagnostic testing, UA is obviously the gold standard. And to kind of break this down a little bit further, when you get the UA, you're going to want the UA with micro, because that's going to give you like different cell lines, different casts that may be present. And then you also want to get some chemistry aspect of it. So this is going to be like a sodium or urine sodium, urine creatinine, and then urea if they've been on diuretics. So if they haven't been on diuretics, you can just get the sodium. But if they have been on diuretics, you're going to want the urea. And so there's two different calculators that we'll use, and this helps us determine whether or not it's pre-renal or ATN. That's your question. So the fractional excretion of urea is for patients that have been on diuretics. And the fractional excretion of sodium is for somebody that has not been on diuretics. And you can see the formula down there. And you can just Google med count and you can find these two calculators pretty easily that you can calculate it in. And so if they, again, going back to what type of renal failure do they have? This FeNA or urea will help us determine. So the fractional excretion of sodium, if it's greater than 1%, that's ATN. If it's less than 1%, it's pre-renal. And the fractional excretion of urea, if it's greater than 50%, it's ATN. But if it's less than 35%, it's pre-renal.
Does it matter how long they've been on diuretics? Just like any.
I think if they're presently on it. Yeah. Yep. So if you guys want, maybe just Google med count. That way you guys know how to find those. And then you just type in
Gold star list.
yeah, or find or just type in FeNA. Yeah, fractional excretion of urea. You'll find it. So this is like the gold standard urine test. Okay.
These like hurt.
Say that again?
Sorry, did you say, oh, is it 24 hours?
No, this is just a urine. It's just a regular UA. It's not a 24-hour urine. Yep. 24-hour urine we wouldn't do in somebody with acute kidney injury. That's going to be more like we're thinking they have some underlying chronic disease process. So for those of you that want more detail, more of a chart, here's the chart form. I put it in red. I'll remind you, this is something you yeah.
Loud and clear.
Yes. Yeah. And so if you want a little bit more detail on what like a specific gravity might be, what the urine sodium might be, and pre-renal or ATN, this is, I think, a little bit more helpful. So also know too that when you get that microscopy, it's going to tell you what other kind of cells and sediment and stuff might be in there. Pre-renal, it's going to be benign. There's not going to be any white blood cell casts, red blood cell casts. Kind of the thing that you may see the most in ATN is that they may have these epithelial casts or these granular casts. It might be more like muddy brown in somebody with ATN. Also, too, another kind of big red flag that it's pre-renal or ATN, whether urine sodium is. So less than 10, typically pre-renal, greater than 30 to 40, usually ATN. Okay. So this is, again, just sort of a nice, helpful, but not necessarily something that I would expect you to embed in your mind. But just the different microscopy interpretation and the presence of the different kinds of cells that you may see and how that can kind of help you understand what type of acute kidney injury they may have. So. Kind of talked about this a little bit with the renal ultrasound. You know, not necessarily something that you have to jump to right away, but particularly if it's pre-renal. I thought this was a helpful slide. You know, as we talked about like the different stages, but a lot of times you don't see it. But this is a nice like snapshot of a management approach to patients that have acute kidney injury. Obviously, discontinuing all medications that are nephrotoxic is important. Ensuring their volume status and their perfusion is appropriate. Obviously, monitoring their creatinine and their urine output. The avoid hyperglycemia, that's more like an ICU level of care thing. Obviously, not giving them contrast if you can avoid it.
So what is your guys' take at Mayo about the contrast, if there's neuropathy and nephropathy and whatnot, like up in the Twin Cities, St. Paul Diet or radiology, or like, we don't believe in it.
Yeah, I know. I wouldn't say that. I think, and you guys will find this, that if a patient has acute kidney injury, there's going to be so many different reasons why they have acute kidney injury. It's not going to be just one. You know, they're going to be diabetic. They're going to be hypertensive. They're going to be on an ACE. You know, they're going to be on glucophage because they're diabetic. And then we give them contrast. But then they were septic and had shock. And then, you know, they had a GI bleed at the same time. I mean, that's the reality of inpatient medicine. And so I don't think we would ever just peg somebody to say that that is the one reason why they have renal failure is the contrast. Because it's always so multifaceted in these patients that it's really hard to say that it's just the contrast. Does that make sense? Is that kind of your guys' take on it too?
Yeah. So you oftentimes will have the banter back and forth. You know, you'll have surgery say, no, we need the image. You have some nephrologist or radiologist will say, no, we're not doing it.
Yeah.
And then you have other or radiologists who say, we don't believe in it.
Yeah.
And so we often will say there's so many other reasons to say
Yes.
they do.
Yeah.
And that's the big thing is you're looking at different practice patterns and even an 80-mile difference, how places can practice very different.
Yep. Absolutely. Okay. So some management tips. Again, this is a red one, right? Yeah. Good.
Really not distill this down.
Good. Yes. Exactly.
Not that it's not always.
Well, yeah.
Right. No.
Right. Agreed. And like I said, especially with acute kidney injury, when it's like when you look at the data, and 90% of it is going to be renal or ATM. Like anything beyond that, you're going to consult nephrology. And if you happen to work with a nephrology service, you're going to learn it then. But in terms of management, of course, we want to be preserving kidney function, right? So these are the basic nursing things: intake, output, daily weight, basic stuff. You want to be monitoring their volume status. All of those nephrotoxic medications that we give, they are contributing to the picture. Hold all of those, right? You're not going to still give diuretics to somebody who's in pre-renal failure because they're dehydrated. This doesn't make sense. So if somebody had obstructive renal failure because they had a bladder full of urine, what do you think we're going to have to do? Put a Foley in. And that's going to stay in until they go home. And then they'll follow up with urology as an outpatient. And then at that point, they'll decide whether or not it can be taken out. Okay?
And then this is the like big take home point in there for patients that we're gonna go over. So, indications for emergent dialysis. This is, I have found this mnemonic very helpful for me, because it's not uncommon in the medicine 9 service that I work on. We take a lot of cardiac monitoring patients, and a lot of them have associated electrolyte abnormalities and renal failure. But our unit sometimes is not necessarily the best spot for them, because their potassium is too high or their volume overloaded, and they're getting to the point where they really need emergent dialysis, but we can't accommodate that in our unit. So you've got to have like this knowledge in your back pocket to be able to communicate and say they're not appropriate for our service. And so these AEIs, O's and U's are helpful to be able to help yourself just kind of know specifically when a patient's going to need dialysis. So first one, A, acid-base abnormalities. So again, this is helpful stuff that I went through the guidelines myself and just snipped what I thought was important for you guys to read and know. But basically just know that in terms of acid-base balances, that there really is no like specific, their pH has to be this in order to have dialysis. But kind of as a general rule of thumb, once they're getting to like 7.1, 7.2, that's kind of a range where you may start to think about dialysis for that. Using bicarb is pretty controversial, and so I don't think you'll see that much anymore. Once their BUN gets to be about 80 to 100, again, that's in the range of, we should be considering dialysis in these patients. And again, I highlighted some guidelines for you guys that you can read through. Also, if they have ingested things, those medications for these drugs, like ethylene glycol and methanol, basically they're found in like paint burners, antifreeze cleaners, fuels, de-icing solutions, things that we generally wouldn't want to partake in, but some people like to partake in them as a drug. I think they're used in like meth and stimulants and such.
I think we've had people that drink that. Yeah. Because they run out of other stuff, and so they just start drinking whatever they can find. Or we've had people who was like loved ones or not loved ones, I guess, would put it in their drinks. Like we have this guy that was mixing drinks for his girlfriend, and he was just adding a little bit of antifreeze as a topper, like an antifreeze book.
Other parts of the world too, we've added to alcohol. So,
Yeah.
Dominican Republic just had an outbreak.
Oh, really?
Just fatalities due to glycol added to alcohol and the drug and stuff.
Good to know.
Back in France.
Yep. Yeah. So even if people ingest too much of this, it'll drop their, it'll make them become metabolic acidosis, drop their pH. It might be an indication for dialysis. So look at this EKG. You can probably see it right on your laptops, but we're going to move to the letter E, and this EKG finding is associated with abnormality. That's important.
P wave there.
Good job. Good job. So hyperkalemia. So obviously looking at electrolytes is extremely important in these patients. It's also important for you guys too to start to know what are your policies and procedures in the institution that you're working in terms of what level of potassium requires an ICU setting. So at Mayo, if it's 7 or greater, they have to be in an ICU setting. That's like an indication for emergent dialysis. Also, just some fun facts about EKGs and hyperkalemia. Know that if you have a patient that has like chronic kidney disease and they frequently get hyperkalemia like the day before their dialysis or the morning of the dialysis, you're not probably going to see EKG changes much on them. But say you have a patient that threw a clot to the renal artery and now has a dead kidney and are hyperkalemic, and they've never been hyperkalemic before, you're going to see changes on their EKG a lot sooner. And so those PT waves are like the first thing that you're going to see. And then that QRS is going to start to get wide, you're going to drop a P wave, and then eventually get into ventricular arrhythmias. So I had a patient at 8 once talking to me with, like, he had no P waves, and his QRS was really wide. And thankfully he was talking to me, and it didn't seem like a problem, but we got him to the ICU quite quickly, which was good. But also know too, they may have some other things like muscle twitching, irritability, anxiety, other PVCs, EACs kind of associated with it too. So treatment of hyperkalemia, we kind of classify it into more of a mild, moderate, and severe classification. So once you get to that like 6 range, and a little 5.5 and 6, you probably want to give them something that would help remove some of that potassium from the body. And it's really going to depend on the type of patient that you have and what medications you give. So if you think about it, if you've got a patient that is admitted with diarrhea and has acute renal failure from dehydration, do you probably want to give them Kayexalate? Probably not. So you have to think about those things when you're choosing the different medications that you would like. Once you get into that 6 to 7 range, you really need to focus on what medications are going to shift it into the cell and then ultimately remove it from the body. And then that moderate and severe, that greater than 7, again, this is going to be more like we need dialysis, we need calcium gluconate. And so I made you a nice slide table and I put all this together, and again, it's red. So this is important. Of what medication choices you have, what severity of potassium number it could potentially be used at, how it acts, and then also some various just considerations when you do it. Yeah.
We've had nephrologists that say that they can't like.
Really?
Yeah, so that it takes a while.
It does take a while. Yep.
And in fact, like Regent's Hospital, I got a call from pharmacy because I ordered Kayexalate the other day, and they're like, we won't use it, we can't use it. And our nephrologist said it was a change made in a silo, and nephrology wasn't aware. Nephrology's like, just give them Kayexalate.
Yeah.
They won't. And they're like, what do you mean they won't? They ended up calling. We got told the same thing. We ended up having to do albuterol, insulin, and calcium because their perspective was they were concerned about when too many issues and the length of time.
Yeah.
So I think we may find that this is the beginning of Kayexalate going out of favor, and in 3 years it may come back in. Who knows?
Yeah, no, I know. Yeah, I think there's a lot to it. I would never give it to somebody whose potassium is 7, because I know it takes a long time to work. But if they're like 5.7, 5.8, and you know they don't have acute renal failure, and they can mount those potassium diet, those sort of things, then I think it's definitely there.
We have those patients that are like chronic dialysis patients that like you said are hyperkalemic and they take it every day, like 15 grams
Yeah.
once a day. And they live just fine.
Yeah.
With a 5.0.
Yeah. Yep. I know a long time ago there wasn't sorbitol that was in it, and that sorbitol is what increased their risk for like gut necrosis if they didn't have bowel movements. Well, they've taken that out. Sorbitol's not in there anymore, and so that's why we can continue to use it. But you know, just some other things to be mindful of, like the albuterol. You know, you have to give a really high dose of it in order for it to be effective in patients, like 10 to 20 milligrams, and typically we only give like 2.5 to 3 milligrams in it. So if you've got somebody who's, you know, got a potassium of 7 and they're having PVCs and PACs, and now you just gave them a bunch of albuterol, that's going to, you know, increase their heart rate, and that's probably not a good choice, right? Or they're having a COPD exacerbation or already very wheezy, and you give them that much albuterol, they can have some bronchospasm associated with it. So this is where you kind of have to be mindful of what's your patient's initial presentation and which one would or would not be appropriate today.
Pretty much like a protocol.
Right, we do have a, yeah,
I know we do it at Downhill.
yes. I don't know, Scott, you guys have a, like, electrolyte replacement or electrolyte treatment?
We have that was like a replacement protocol, but half the time the patient, because of the creatinine, they don't.
Right.
And then our go-to for your hyperkalemia is typically if they're stable, doing calcium gluconate or chloride. Remember, what you're doing there is you're stabilizing the cardiac membrane, and it's a short half-life. But we're getting more into insulin and albuterol. And then there's a lot of nursing education that goes, and a lot of patient education that goes.
Yeah, I'm not on COPD. My wife does, but I don't.
Right.
But we're not giving it for your breathing, we're giving it for.
Yep.
Good. High levels of magnesium, very uncommon for it to be a problem in renal failure. Usually they're not hitting the levels that typically cause problems for patients. Usually when they get to be that like 4 to 6 range, that's when you start to have symptoms, and typically it's not something that you would see with acute kidney injury that they're going to get up to be that high with magnesium levels. Hyperphosphatemia, this is more kind of a chronic kidney disease problem rather than acute. And then we now moving on to the vowel I, intoxications. I mentioned this already. What does this chest X-ray look like? Yeah, an large cardiac silhouette. What else do you guys see? Yep. So what does that go with? The letter O for overload. Yeah, good job. So again, another indication for urgent or emergent dialysis is overload. So obviously doing a good physical exam on your patient if they've got signs of pulmonary edema. This might be somebody that you've got to start CPAP, BiPAP, potentially intubate if they're in horrible pulmonary edema. Know that the use of Lasix is pretty controversial in these patients. And again, I went to the guidelines and I snipped for you guys the recommendations on this, and that we only should be using diuretics for patients for volume overload, for example. We shouldn't use it like, for example, if you think they have acute kidney injury, well, how do I say that? So where you may see this is like, you have a patient that had really bad ATN, they had to go into dialysis, and they started dialysis, and now you're trying to get them off of dialysis. Their kidney function's recovering, but you just need sort of a temporary thing, and they're volume overloaded. It's okay to give it just if they're volume overloaded. Does that make sense? Yeah, okay. Just kind of snipped out some other guidelines for you guys to read through. Oops. Okay, so the last vowel, U, so indication for urgent and emergent dialysis. Think about uremia. Okay, so this is a nice picture of all of the systems and what you may see if a patient is uremic. Okay, so main thing to think about is from a neuro perspective. If they're drowsy, lethargic, they're confused, decreased level of consciousness, kind of the main thing with uremia. What might you see from a cardiac perspective? Uremic pericarditis? Yeah. So what would you maybe hear on physical exam? A rub, yep. So you may catch that on physical exam. So if they have signs and symptoms of uremia, that's an indication for emergent or urgent dialysis. So this is a 12 lead here. What do you see on this? ST elevation. Yep. Do you see it in leads that just correlate with one geographical area of the heart, or do you see it in multiple? Multiple. Yep. And then look at that PR. What does that PR look like? Depressed. Yep. So if you have PR depression, multiple leads, ST segment elevation, multiple leads, what's that a sign of? Pericarditis. Yes. Good. So this is a snippet. I have the vowel method, the A-E-I-O-U, but the up-to-date says that dialysis should be considered in patients with acute kidney injury if they have hypervolemia and pulmonary edema that doesn't respond to diuretics. They have severe hyperkalemia. They say 6.5 or greater. Again, know your institutional policy as to where your patient may lie with that. Life-threatening uremic symptoms, or exposure to those different toxins that we talked about, the antifreeze, pain thinners. Yep. So one or more of those, that's an indication for urgent or emergent dialysis, and they should be in an ICU.
I noticed that this is red. Okay. So just a few other kind of touch points on treatment, pre-renal failure, that ATM. Again, it's going to be like 90% of what you see. So if you remember this, you're good. The AEIO is in use that we just talked about. The careful fluid balance assessments, the dietary restrictions, making sure that you're putting them on the low potassium diet, the low protein diet. Potentially restricting their fluids if they're volume overloaded. But
They won't be happy with you.
no, they won't. They're not going to like it.
That's,
Yeah. These patients are probably going to need daily, if not maybe twice a day, electrolyte monitoring. And if it's pre-renal, lots and lots of fluid. So more of those uncommon causes of intrarenal failure, that acute interstitial nephritis. Again, remember the most common is medication listed there. Infections, autoimmune processes that have progressed. That's going to be like your lupus nephritis, stuff that you just don't see a lot in the hospital. But if you have a patient that, say they're coming in with worsening renal failure, they have lupus, they're increasing their creatinine, who do you think you're going to want to consult? Well, yeah, definitely nephrology, but who else? Rheumatology, right? Because they probably need changes in their immunosuppressive medications. And unless you work in rheumatology, you're not going to do that. Okay. If they have a recent strep infection and now they have strep glomerular nephritis, in addition to nephrology, who might you also contact? Yeah, ID. Yep. Good. Just some other take-home points with this in terms of acute interstitial nephritis. If you do see this and it's because of a medication, obviously you're going to stop the medication, right? One other thing that you may see in this patient population is in their UA, they may have some positive eosinophils. It's not highly specific or sensitive, but it is something that is kind of unique to that disease process. And they may also have associated rash with it. So we talked about post-obstructive neuropathy a little bit about putting a catheter in place. Usually, if you put the catheter in, just a straight catheter, and if they're getting more than like 400 cc's, that's probably an indication to just leave the catheter in for them. And they're going to discharge with it. So obviously, they're going to have some education and teaching on how to manage that at home. Sometimes in those patients, when they do follow up with urology as an outpatient in a few weeks, they will do like voiding trials for them. So they'll have them, clamp the Foley catheter for a while, see how much they're retaining, take the catheter out, and then, try to see if they are able to empty their bladder fully. That's something that's kind of done as an outpatient. Also, too, if you're thinking about, if they have acute urinary retention, lots of urine in the bladder, look at their medication list. You think about all of these different medications that can cause urinary retention. And so you may need to be eliminating some of these classes of medications from their profile. Also with, sorry, that was a little backwards, that slide was out of place. If they do have obstructive uropathy, also think about what Flomax, finasteride, Prospar, those probably need to be started in an inpatient setting, which is something that they take several months to work, so it's not anything that you're going to see right away. Do you guys remember the Flomax? What's a pretty common side effect in the elderly with that you have to be careful of? Hypotension, yep, absolutely. Be careful. It's always a good rule of thumb, especially if you start in an inpatient setting, do a set of orthostatic vitals on the patient before you leave. So if they're having some orthostatic hypotension, the last thing you want is for them to fall when they get home. Okay. So after this slide, my zebras and horses, this is all more uncommon things that you're going to see. And you guys can kind of read through that on your own. We kind of talked about rhabdo a little bit already. So know that with rhabdo, obviously you're going to check a CK level. Also check a urine myoglobin. That's the myoglobin to break down muscle. They can then be excreted in urine. And then also know too that usually when their levels are about 15,000 to 20,000, that's when you may see acute kidney injury associated with it. And that you should continue fluids on those patients until they're like less than 5,000. Is the rule of thumb. And then, you know, if they do get volume overloaded with aggressive hydration, you can give them some Lasix. With that, you know, obviously treating the electrolyte abnormalities that would go along with it, the hyperkalemia that we talked about. It's uncommon then for them to have high levels of uric acid too. And so you need to start some allopurinol with it. And then I have other slides on here, just again, more uncommon things, but cardiorenal syndrome, hepatorenal syndrome, contrast-induced nephropathy. But if you guys can just remember those highlights of things that we talked about, you'll be good. Like I said, these are more like uncommon things that you just don't see that often. Maybe just to highlight a little bit with the contrast-induced nephropathy, how we had talked about that. I did go to the guidelines and snippet what they recommend, and they do recommend volume expansion with an isotonic sodium chloride rather than just increasing oral fluids. And they did say that there's not really anything to suggest not using the acetylcysteine, and so it's okay to use acetylcysteine. But I don't think the evidence really supports a yay or nay either way. I think sometimes we just give it because we know that it doesn't hurt patients, and there's really not a contraindication for it.
We talked about that earlier on this part.
Yeah.
Did David say we don't forget?
We do, I mean, still intermittently. But I don't think the evidence will really tell you either way. But the guidelines did say if they do have a high risk for developing,
So for Tylenol, yes, Tylenol with the overdose and acetaminophen overdose and whatnot, it's highly encouraged. The others, the pendulum has swung from, it used to be probably in the early 2000s to the mid 2008, 2009, that anybody that was at risk for AKI was pre-treated with NAC. And so we all got on the bandwagon, and it was almost herd mentality. We went down this path.
Yeah.
And then we started looking at the literature saying, it doesn't hurt, but we don't know how much benefit it is.
Yeah.
So then the pendulum came back this way.
Yeah.
And now we're kind of coming back more in the middle.
Yeah, and so I think, again, if you have this patient who is, say they're diabetic and they have hypertension and they have heart failure and they take a bunch of diuretics and ACE inhibitors, you know that that's going to be a high-risk patient to potentially get some issues with contrast. That's going to be somebody that you're going to want to treat. You know, you're 35-year-old with no medical comorbidities and no medications, probably don't need to do it. Does that make sense? That's one of those, like, medicine has become a little bit of an art than a science. That can be really, that can be kind of challenging to like know how to navigate. But like I said, I went the guidelines and I snipped.
So you can never be, you know, from a practice standpoint, you can never be penalized for defending your practice
Yeah.
based on that.
Yep.
You can get penalized for not following guidelines.
So this might be a really stupid question.
No stupid
Like,
question.
If I'm looking for a guideline and something I'm not completely, like, something I've not dealt with.
Yep.
Like, there's different people that sponsor different guidelines.
Yes.
How do I even begin to find the correct guideline? Do you just like,
So what I've done is a very good question, actually. I would do whatever body system and their society. So if I'm looking at GI, I'm going to go to the American Academy of Gastroenterology, and I type in American Academy of Gastroenterology guidelines and PEPC, or American Kidney Association, or whatever guidelines. There's going to be some varying degrees of difficulties. What you will not often see is conflicting information where one says absolutely do it and the other says don't do it.
Right.
So.
Yeah.
That's a good spot to go, is to go whatever organ system, their association, so American College of Cardiology, American Lung Association.
so people,
Yeah.
are they like, ask me,
Yep.
or something, are they like embedded in there, to get started that way?
Yes, so like if you go to Ask Mayo Expert and you type in whatever you want, like acute renal failure, it's actually really helpful because it gives you this nice sort of algorithm, and it'll go like your history, your exam, your diagnoses, or your diagnostics, and then like if this happens, then do this. If this happens, do this. So it's a nice sort of algorithmic approach. And the Ask Mayo Expert, the people that write that content, they are people that have looked at all of the different guidelines from the different professional societies and have determined like this is what we should be doing. So that's definitely a good go-to place. And if you have further questions, a lot of times within Ask Mayo Expert, they've embedded the guidelines, so you can go right to the guidelines. Yeah, and if you hit Control F and you type in whatever you want, it'll take you right there. So I'm sure you guys know that trick. But.
And to sound it too, like, just thinking of this people, like, with, there are different bodies out there in different systems of what says this is what we should do for treatment, this is what we do. But like, as a stroke center here in Rochester, you have to like say you follow the American Heart Association guidelines of this, this, and this, and that's the guidelines you follow. And so all your policies and procedures are based off of those guidelines, and that's kind of the standard of care that you are kind of have to follow.
And even too, like if you go to Up to Date and you just type in whatever you want, hit Summary and Recommendations, it'll give you the treatment. Yeah. So.
The other next good place to go is also Up to Date.
Mm-hmm. So.
I think that's all I have that are common stuff. Like I said, this is all uncommon stuff. And if you are looking at patients for multiple myeloma, renal failure, and all that, then it doesn't happen very often. So
I actually came across that during my clinical.
Oh, you did? Good. Yeah. Yes. Good. What else? What other?
The family decided to withdraw anyway.
Oh. Yeah. Yep. Yeah. So yeah. Yeah. So think about with multiple myeloma associated renal failure, they're going to have elevated light chains. You'll check a SPEP and a UPEP, which help you find those light chains. You can do it by urine and by blood. And then, what other kinds of electrolyte abnormalities do you think they would have? Hypercalcemia. Yep.
Maybe the slim crab.
Do a what? Oh, I didn't know that one. That's good. Yeah. So high calcium, high phosphorus. Usually, maybe they have obviously more like bone mets you might be capturing on imaging that would kind of help solidify that. Compression fractures, yep. Absolutely. Okay. You guys brain fried? Yep. Remember the red slides. Yeah, remember the red slides and like I said, with renal failure, it's usually more than one thing that's contributing, so, and like I said, 90% of it is gonna be pre-renal or ATN. Everything else is definitely more of a zebra, not so common. Okay. Do you guys have 15 minutes in you to look over that case study that I posted? Okay.
I have it in the, oops. I have it on D2L.
So this is like a legitimate consult, very legitimate consult, like a true story consult. And, we intermittently will do medical management for our orthopedic surgery colleagues. This is a legitimate consult.
Is that everything on those 2 pages? There you go.
Yeah.
Okay.
All right. Read about this young. She's on general surgery service. And she had 3 days of abdominal pain. She's got acute diverticulitis. And she was being treated initially as an outpatient with flagell. And because she was still having nausea, vomiting, she couldn't eat or drink much, and a low-grade temp, she was admitted to the surgical service. And her creatinine was going to be 3.5, and she runs a baseline of 1.2. And now she's 3.8. And initially, she was started on some IV fluids, 150 an hour, or no, sorry, 125 an hour. Was having some lower urine output. She's diabetic, she's had an MI, she's had CABG, she's got systolic heart failure, and she's had a history of stones and depression, and that is for MedList there. But over the last 24 hours, her urine output has picked up, and she is now positive 1 liter of fluid. Her weight is stable, as you can see. Really nothing crazy on physical exam. You can see her potassium is kind of mildly elevated, 5.8. Otherwise, her white count's good, hemoglobin, hematocrit, and all that are fine. You can see what her UA shows there. She's got greater than 100,000 white blood cells. She's got some white blood cell casts, a little bit of RBCs. She's got positive eosinophils in her urine. So let's talk about her a little bit. From a broad category perspective, why might she have pre-renal failure? Dehydration. Yep. Meds. Yes. Which ones in particular?
Antibiotics.
Yep. The ditch, the Lasix, the aldactone, the lisinopril, the metformin, the Cipro, pretty much all of them, right? Good. What would be some intrarenal causes? Potentially. Yeah, she potentially could have progressed to ATN, right? Yeah, so now she's got actual damage to the tubular areas of the kidney. What else? What? Yeah. Yeah. Acute interstitial nephritis. Yep. What in their past medical history? Yeah, those two. Yep, so now let's talk about post. What are some obstructive causes? Her history of stones. Yep. We don't know if she has a catheter in or not. So we don't really know if she's retaining urine. So it'd be nice to know if she is retaining urine or not, if she has a Foley in. I didn't list out maybe what PRN meds she could be getting, so think about, is she getting, and yeah, is she getting narcotics that could potentially make her retain urine? Is she be getting Benadryl to help her sleep? Those kind of things. Yep, confidine. Yep. I don't know, it doesn't sound like she's been agitated, but maybe she's getting some Tylenol or something that might make her retain some urine too.
We talked about how long earlier.
Yeah.
Oh, yeah. Good stuff. Yep, good. So she's got lots of reasons why she might have renal failure, right? All right, so, plug in those numbers into MedCalc. Now you'll have to think about whether or not you want to use the fractional excretion of sodium or fractional excretion of urea on her. Which one? Perfect. Yep, good. So plug in her lab results into that calculator and see what you get. For the fractional excretion of urea. So what does that lead you towards? Is this pre-renal or ATN? Yep, so she's probably progressed to an ATN if she's greater than 50. ATN, yeah. What else in her UA is a little concerning though? The white count, yep. And so you see a really high white count like that, what should you think about? UTI, yep, so is she having any symptoms? She's been on Cipro, so. Maybe
She's
not.
got a 10.
Yep, she does have low grade temp, yep. She's also got some casts, right? Some right blood casts. She's got a little bit of blood's not uncommon to see with the UTI either. But then she also has some eosinophils. So that kind of points us down more towards the acute interstitial nephritis, allergic interstitial nephritis picture. So she's got a potassium of 5.8. What do you think you should do about that?
There were some kids like.
Yeah, yeah.
There's a bunch of trees up there.
Good thing you're working urgent care that day, you can say, sorry, go to the ER.
Yeah, exactly. Yeah, so you probably make an EKG, right? Just to see if she's having anything, because this isn't somebody who has been exposed to chronic kidney disease. And she may have some EKG changes that would be important to understand. Yeah. When you look at that, when you think about that slide that I had with everything on there, KXLA is probably not a good option, right?
No.
She's having diarrhea. So what are some other choices you might want to do? What?
Go with the calcium-gluconate, insulin.
Yeah, insulin D50.
What's easier, what's easy, yeah, readily available for them.
Yeah.
What can you plug into the wall?
And she's probably somebody that might be able to tolerate it. It doesn't sound like she's got severe COPD or anything like that. That might be over the edge or having arrhythmias. Do you think she needs a kidney biopsy? Yeah. Yeah, probably not right away. Yep. So with the acute interstitial nephritis, it's likely from a allergic type reaction. Oftentimes just withdrawing the offending agent is going to be okay.
And what quick lab could you pull? No, just see if it's, allergy.
IgE.
You can check the differential on the CBC to check to see the presence of eosinophil.
Yep.
If there's eosinophils, then that kind of helps guide your medical decision making.
Because if you look at her CBC, she's got eosinophilia.
This is where we're putting the puzzle together.
Yes.
Because you can do a renal biopsy, the problem is, this is more of an acute issue. The chronic it's good for long-term surveillance, but the person's coming in, I don't know what you guys do at your facility, but our patients get admitted for 24 hours post-renal biopsy for risk of bleeding, and they're on their back for 6 to 8 hours. And so they're all, yes, let's do it. And then they hit the floor, and they're not very happy because they still have to be flat on their back. And it's not a very comfortable procedure, so, yeah, they're going with essentially a harpoon needle or a CAT scan.
Yeah, so typically in allergic interstitial nephritis, withdrawing the offending agent is going to help improve their kidney function. And she's got other reasons why she may have some AKI on top of it too, right? If you stop those offending medications, make sure she's not dehydrated, make sure her volume status is appropriate, she'll probably start to get better.
Because she's on so many nephrotoxic, how are you gonna, I mean, I know you're gonna withdraw all the
Yep,
acid on,
yep.
how do you get to a bottom of which one you're gonna do?
A lot of times you're not going to know.
Some of the right, I mean, you can switch some of them around.
Yep. So, yeah, in allergic interstitial nephritis, kind of your train of thought is stop the medication. If they don't get better within a few days, then at that point, like that's a consult nephrology. They probably need some prednisone, immunosuppressive therapy, and that's going to be something that they're going to continue for like 4 to 12 weeks. And that's all, obviously all going to be outpatient stuff. And if they're not getting better, then at that point you may biopsy.
You said, what?
Prednisone. Yep.
So the fact that this probably is due to like the addition of her antibiotics and she was on the other nephrotoxic ones first.
Yep.
Would you just like cool those back first, or would you try to?
Well, definitely, because she has a positive eosinophilia, you would stop the antibiotic first, right? So then, if you look at her list, if you start to think about kind of process of elimination, she doesn't need diuretics, right? The lisinopril, her blood pressure, I believe, was okay. Probably doesn't really need to have that right now. Definitely the metformin, we've got better ways that we can control the blood sugars, right? So we can take that away pretty easily. And then the DIG, that one's a little questionable, because she probably needs that for underlying arrhythmias, right? But what do you think you should do with the dose of medication that she's on? Probably gonna have to cut it back, right? And so this is where it's gonna be important that you connect with your pharmacist, say, hey, can you help me dose this DIG out? Check a DIG level, and then you're probably gonna wanna do it, maybe every few days to make sure that it's not continuing to increase. Now, if she was having DIG toxicity symptoms, I would obviously stop it. And what would those be?
They have like yellow vision.
Yeah, they see like little green, yellow halos around lights. They can have nausea, vomiting with it. They can also.
EKG changes.
Yes, EKG changes, absolutely. Yeah, so you're getting that EKG for the hyperkalemia. Also look to see, are they having signs of heart block, a slow ventricular response, like heart rates into the 40s, 50s. That would all be signs of DIG toxicity that you would be a little bit more apt to stop that than just continue it if they had no other signs and their levels were okay. That's kind of how you would think through, I think, that process of elimination. Yep. And like Scott was saying, renal biopsies, we don't take those lightly. That's not something that you're gonna just see people jump on doing that, because they are such a high risk of bleeding. And so those are the patients, like they can't be on aspirin, they can't be on Plavix for a week prior to the biopsy. What about their blood pressure? Do you think you can biopsy them with any sort of blood pressure? Yeah, you're gonna want them low, like less than, I think, and this one, I don't know the guidelines off the top of my head, but I would say like, from what I remember learning about it a long time ago, like 120, 130 is you want their blood pressure less than that, going into the biopsy and even after the biopsy, because they're such a high risk for bleeding. Yeah, right, exactly, yeah. Yeah. That is kind of a board question. Yeah. Yeah, so we don't get those kidney biopsies likely. So when we talk about complications that can happen with acute renal failure, remember your A's, E's, I's, O's, U's. So they can get acidotic, the electrolyte abnormalities that we talked about, hyperkalemia. Intoxications, doesn't seem like this fits her picture, but O, overload. So she had pulmonary edema, elevated JVP, extra heart sound, peripheral edema, needing lots of oxygen, that she would need urgent dialysis. Or is she developing uremia? Is she getting confused? Headaches, seizures, fatigue, pericardial rub, pericarditis.
And remember, uremic frost is a big symptom. Unfortunately, I say that in jest, but a lot of our medical colleagues who are learning this, they'll go, well, how can they be in uremia or uremic if they don't have the frost? Or that even, an acute issue is the skin manifestations are lack. And renal failure is right up there with iatrogenic anemia. Number one cause of anemia in the hospitalized patient is blood loss. Same thing with acute kidney disease. Oftentimes, I can't, when I'm doing a perimedicine consult and, you almost feel like it's common knowledge, but you have to put it, risk for renal insult, moderate, low, high, and the tagline, avoid intraoperative hypotension, avoid, nephrotoxic agents. Because when we get a consult, first thing we do is we look at the anesthesia record in our facility as they actually now have their own tab, and we can point when they became hypotensive. And so.
Are these patients followed up closely to watch their GFR and make sure they're not developing CKD? Is that a risk for them?
Well, the problem is most of these people are not the best medically managed as far as wellness. They've got a lot of chronic medical issues. And what happens is we have rheumatology doing one set of things. We've got cardiology doing something else. Oftentimes, especially if you're not in the Rochester area and you're in the Twin Cities or another major metropolitan area, you have different healthcare groups managing. And we don't have the gatekeeper who's saying, oh, rheumatology, before you go jack them with these meds, make sure that we're talking to nephrology, and patients, either they do everything you say or don't do anything you say. And so those are the big challenges. But, that's one of the reasons as say, if you're on a hospital medicine service, I think it's prudent that people go back and they see their primary care provider 1 to 2 weeks after discharge, so that changes that we made during the hospital stay, either they can continue those changes or they can make additional changes and follow up on labs. Oh, absolutely.
Oh, yes, exactly. And she probably has, based on creatinine 1.2, maybe she is.
And also keep in mind that, for especially acute kidney injury as well as chronic kidney disease, the GFR and our serum creatinine, they're surrogate markers. They're best what we have at the moment, but they're only a snapshot in time. And they're going to lag 24 to 72 hours. So like I'll typically say repeated BMP. If I had somebody like this, I'd say repeated BMP 1 to 2 weeks post-discharge. And I'll even order it in the discharge order set so that at least that as a hopefully fail-proof safe mechanism, they'll go get it, but at least it's been encouraged. And so this is real pathology. And as nurse practitioners, we are quite capable of managing patients like this and those who are much sicker.
And one thing that was really hard for me as a student and as a beginning provider to want that, why did your kidney numbers go up? Why did your creatinine go up? What was that one thing? And to really become comfortable with the fact that it's probably not just one thing, right? It's multiple things. And that's, I think, where as you start to grow as a clinician, you're going to start to see that there's multiple things that contribute. And that's why, hopefully it was helpful to work through, again, not just system differential diagnosis, but differential diagnosis of the actual problem. I hope you understand that piece of it. Make sense? Okay. And hopefully, like I said, snipping out those guidelines for you guys, helpful too. Because it was 143 some page document, and oh.
And make sure that you guys are getting the updated stuff. Oh, yeah. Any questions?
Is everybody brain fried?
Yeah.
Yeah, what?